infectious diseases, research, medicine, health. Welcome to Outbreak News Interviews. And now, broadcasting from the Outbreak News Skylar Studios in beautiful West Central Florida, here is your host, microbiologist and editor of OutbreakNewsToday.com, Robert Harriman.
Well, July is International Group B Strep Awareness Month, and my guest today is here to shed some light on this very important bacterial infection. Joining me now is Dr. James A. McGregor. Dr. McGregor is a retired obstetrician and infectious disease specialist and serves on the board of the Group B Strep International, an awareness organization. Dr. McGregor, welcome to the show, sir.
Thank you very much, Robert.
Okay, well, let's go ahead and just start out with the most basic question is, what is Group B Strep?
Group B Streptococcus is a kind of Streptococcus which was actually by Pasteur, who's one of the patriarchs in terms of bacteriology, and he actually observed this microorganism, which he called a Streptococcus, along with other kinds of similar bacteria, by working for the Paris government. It turned out that in Paris in the 1890s, they were having outbreaks of mastitis in French cows which were actually housed in Paris itself, and he demonstrated that this was this cause of mastitis, which was industrially important because it contaminated the milk and caused economic dislocations, was caused by a bacteria which he called Streptococcus. This is interesting. Streptococcus agalactia, no milk, because the milk would dry up in the presence of this suppurative infection. The bacteria was sort of noted for a long time, but in the 1930s, Streptococcus of different kinds, including Strep pyogenes or Group A strep, became more clinically important and was noted, and microbiologists of the era actually were working on the issue of what we now call Group A strep, which causes strep throat, as well as a number of streptococcal infections, which we could talk about later if you want. And they noted that there were two big sort of tribes of the Streptococcus. One was that there was a sort of obvious hemolysis when you put it on media, and this was the hemolytic strep or Group A Streptococcus. And a second group was shown to be not so hemolytic, and that was called Group B Streptococcus. Other kinds of Streptococcus were also noted, including bacteria which we now call Group D or Enterococcus, which is merely found in the gut. But Group A and Group B Streptococcus can also be found in the intestines and in the reproductive tract. And it was noted at that time that Group A and Group B infections both may cause serious infections during pregnancy. But it appears that overall, to generalize, the Group A strep was a much more virulent cause of puerperal or pregnancy-related infection, frequently associated with death of the mother. And these investigations were associated with actually proving that hygiene or cleanliness around birth actually improved outcomes and prevented death of the mother. And it was noted that what was thought to be Group B strep, or Streptococcus agalactia, caused a less serious infection, which was not so immediately lethal.
Okay, and so the Group B strep, the reason we have this awareness month, causes some pretty severe infection in the newborn. But now, is it common or normal for a woman to be colonized or just to have the Group B strep in the genital tract without any infection?
So that's a great question. About 5 to 30% of women actually have Group B strep colonizing their GI tract, and a similar number of their partners, that is the male partners, also has Group B strep in their GI tract, and women have it secondarily in the vagina as well. And men have been noted to have Group B strep in their urethral. And like colonization, so this isn't necessarily causing any kind of symptoms or disease. And so that's from 5 to roughly 30% are good numbers to remember there. It may be also that we're recently sort of demonstrating that Group B strep may actually be found in breast milk postpartum, and this sort of recapitulates the finding of Pasteur, who found that Group B strep was the kind of Streptococcus he defined as Streptococcus agalactia, actually has a predisposition to be colonized in milk as well. And we're not sure of the pathogenesis or what kind of problems that actually causes at this time. But Group B strep overall is from 5 to 30% of populations in the gut. And so this is of interest in terms of pregnancy care, and also preventing severe infections in newborns specifically.
Now, how does Group B strep infect the baby? What types of infections are we dealing with here?
So there's several routes of infections and several presentations. The one that actually caused Group B strep to be finally noticed in rather dramatically was by causing pneumonia in newborns with rapid sepsis and collapse. And this occurred in the 1950s, and 1960s, and 1970s, which caused pediatricians considerable alarm, great enough alarm so that they would actually advise their pediatric colleagues to give penicillin in a prophylactic way. But we've worked our way beyond this. And so in the 1960s and 1970s, say from 1 to 5 babies in 1,000 would actually have symptomatic Group B strep sepsis, and up with a 30% mortality. So this is of considerable importance, and so a lot of interest was put forth to see how we could reduce the risk of infection. And I must say it was our pediatric rather than obstetrical colleagues that led the way here, and that they actually advised different sort of schemes to reduce the risk of infection of the baby at birth. And so the idea was that they would actually reduce the amount of Group B strep in the vagina where the baby was passing through after ruptured membranes and after in the process of labor, and that was considered to be the primary route of infection when the baby was passing through the birth canal. But now we understand that there may be intrapartum, there may be pregnancy-associated infections with Group B strep, which come from either through the blood supply circulating in the placenta, as well as Group B strep that has special enzymes which actually may enter the bag of waters in the placenta and cause infection directly. But that seems to be on the order of several percent of the overall numbers of infection. So it took a long time to discover that.
Mm-hmm. Now, in the baby, what are the symptoms that we might see, and what are there's obviously some severe complications also.
Yes, in my sort of long time practice, the main set of findings in a Group B strep infected baby was that the baby would develop acute onset of septic shock, have respiratory failure, that is, wouldn't be able to oxygenate, and it would have like acute ammonia with sepsis, and then die rapidly within a matter of hours, even in a modern neonatal intensive care unit. And this is very dramatic. In my anecdotal experience, it happened more frequently in mothers who had diabetes or some other cause of problems dealing with infections. And this is very dramatic and tragic. And now And now we and others have described that this can actually happen with as a cause of stillbirth, where the baby appeared to be normal, and then there appears to be seeding of the baby with Group B strep. In our cases, we've described different cases, so this is not a large study, but simply anecdotal observations, where women have what's called a stripping of membranes to induce labor, and this doesn't work very well, but it may place microorganisms up inside the uterus and then give the Group B strep like a head start in terms of causing infection through the vagina. And so we've noticed that to happen as well. Others have now noticed, especially in England, that there may be recurrent late onset of Group B strep, which is after a week after the birth, in terms of contaminated milk. But I don't think that's been characterized adequately in terms of what the risk of that and how it seems to be happening. But it seems to be very rare and is not a cause for not breastfeeding.
Now,
so the main cause of the baby getting infected at this time is thought to be passing through the birth canal and being covered with the bacteria from the birth canal, including Group B strep, and sometimes aspirating these microorganisms in the vaginal fluid, and that causing a virulent sudden onset of pneumonia. So the baby presents with so the baby stops breathing, turns blue, and develops the baby equivalent of septic shock, which it leads to rapid death.
Now, how often?
And
I'm sorry, sir. Go ahead.
And that's the term for that. It's early onset Group B strep sepsis, and that's defined for epidemiological terms to be occurring in the first week after birth or during pregnancy itself. And then there's the other manifestation is late onset Group B strep, which occurs by definition about at least a week after birth. And I think we could say that we're unsure how that spreads to the baby. And in the past, people have postulated, but not particularly proven, that it's like contact with people like me, medical care providers, and other sources in the baby's environment, which leads to colonization and then invasion of the baby with this bacteria.
So, how frequently do we see neonatal meningitis as due to beta strep Group B?
Oh, in the past, in the 60s and 70s, when this was first being sort of more generally addressed, it turned out that pneumonia was the commonest described illness, and that was on the order of 30 to 50%, and then other kinds of infections, including focal CNS infections like meningitis.
Now, you described a lot of horrible scenarios here, and
yes.
And so, what's being done? What can be done to prevent Group B strep from infecting the newborn?
Well, studies in the 70s, again led by pediatricians, primarily from the CDC and in Chicago, showed that by giving penicillin around the time of birth, you could prevent a majority of these infections just by giving penicillin. But that wasn't that was thought to be sort of inaccurate and sloppy by giving so much penicillin. And so another strategy was to define which of the mothers actually carried Group B strep in the reproductive tract or in the lower GI tract. And so what happened, the strategy that was actually then developed was to screen at 35 to 36 weeks of gestation in both the lower vagina and in the anus, and using specialized media, actually identify women who were significantly colonized with Group B strep. And then to give those women, only those women, important doses of penicillin or ampicillin around the time of labor or ruptured membranes. and that appears to be 80% effective in terms of reducing the rate of invasive disease in children. And so that's a great advance, but is somewhat impractical and requires giving a lot of penicillin to a lot of people. And so countries such as the United Kingdom have actually chosen not to do that, but to simply treat patients who are heightened risk because of prolonged rupture of membranes or having a fever or having preterm birth, and only giving those mothers and children the prophylactic penicillin or the ampicillin more selectively. And all of these things have been compared in a cost-benefit analysis, and it appears that the U.S. approach of culturing and then selective administration of penicillin or ampicillin around the time of birth, or if there's other indications, appears to be the most effective, and that's about 80+% effective. So that's a big step.
Yeah.
And it makes actually other treatment regimes sort of difficult to employ, such as like vaccination or other techniques, because we already have a strategy that prevents about 80% of these infections, and it's going to be hard to improve upon that statistically.
Yeah, and it's not just cultures they do. There's different molecular assays now that can give you the result that much quicker.
Yes, we've worked on, those are, you're absolutely right, those are called point-of-care diagnostics, and the hope was that you could do these very sensitive, specific techniques, such as PCR, or something related to that, at the time when the woman comes in, or very near the time of birth. Mm-hmm. But basically at the time when she arrives in labor, and then if it was fast enough and effective enough to actually administer the penicillin only to those women. And that was actually sort of more of a much more targeted approach and use of the antimicrobial agents. And but overall, we helped develop some of those, but it was deemed by the whole community as well as the CDC that it wasn't accurate enough in terms of replacing the strategies that had already been in place. Mm. And so that didn't work out as well as we had hoped.
Okay. Now, you're an obstetrician or a retired obstetrician, and so it's got to be quite a...
Over the hill.
No, never. Yep. But so there's the unfortunate case when you do have an infected newborn. How is that baby treated?
Oh, usually the baby is what's called depressed or having a hard time breathing or being active after birth, and that gets evaluated by pediatricians, and that's called an APGAR score. APGAR score is low, and the baby appears to be very lethargic, not breathing, limp, and then they immediately resuscitate the baby, and by taking cultures and starting penicillin or ampicillin very promptly. And this is done before the return of any cultures or even a gram stain. So this is a very aggressive approach, and this also improves outcomes. But again, the mortality is higher than in terms of just prophylaxis in labor.
Yeah. Now, I don't know if it was last Friday or the Friday before. I really wanted to get your thoughts on this. The CDC has a report called the MMWR, the Morbidity and Mortality Weekly Report, and it discussed a warning to new moms about the potential dangers of taking pills made from their placenta. And apparently there was an Oregon infant's infection that was tied to this practice. Dr. McGregor, would you like to give us your thoughts on this practice and the potential dangers?
Well, yes. Actually, I attended a meeting of midwives in Oregon, in Eugene, a couple of years ago, and there was a display by the makers of these products, and what they had done was to freeze dry placentas and then to grind them up and then put them in capsules. And then I said, well, this isn't such a good idea because you're sort of eating your own placenta. They said, well, that was fine. And customary in some societies, and even a town where I used to practice, which is Boulder, Colorado. And in an alternative communities, that's all well understood. And then I further suggested that the placenta isn't sterile, even though we all think it is, but in fact that's not the case at all, and that there may be bacteria like Group B Strep in the placenta. And then so the manufacturers, the makers of these products, actually responded to me by saying, well, then the mother has it already and may be immune to it. And that may be the case. So the worst case scenario is eating a placenta that somebody else has delivered, that you don't have the normal protective mechanisms to prevent from invasive infection. And I know we're talking about Group B Strep, and that's very important, but there are other viruses and bacteria which are equally important, and that would include a virus that you could discuss another time, which is cytomegalovirus, or CMV, which your population has heard of, hopefully. Yes. And certainly herpes viruses as well as others. I think HIV would certainly be a concern in this situation as well. And so for those reasons, which are infectious disease linked, I would suggest that this is a bad idea, and freeze drying the placenta or preparing it to be used as a pill is an extraordinarily bad idea. Others that I discussed this with would be more alarmed by other things, including the concept that the placenta is actually part of the pregnancy structure or the baby, and you're sort of eating a part of the baby's birth product. And then other people would dog and cat owners would point out that other kinds of animals, including dogs and cats and hamsters, rabbits, actually consume their own birth products themselves, and this sort of thinking is actually very attractive in some populations. Yeah. So it sounds sort of off-putting, but in fact this is enthusiastically followed by some folks. In my practice, I would routinely recommend that actually, if you wanted to take the placenta home, that you actually bury it under your rose bush, because it's in sort of traditional time, it's said that burying the placenta under the rose bush makes red roses actually bloom better. And that's probably the case because of the iron and other minerals in the placenta.
Interesting.
So there might be something to it, but in terms of infectious disease, I think this is overall a bad idea.
Yeah, and I think the CDC pretty much said that, there's really no evidence of any kind of a benefit by doing this either. At least no studies that show that, yeah.
No, this isn't studied at all, but it's actually a commercial product. And I told you, like, the discussion that I had with the vendor, and every one of my objections, they had a response. So that was of considerable interest. And then a little small crowd gathered of people who were enthusiastic about eating their own placentas. And so, again, my recommendation is to plant it in the garden. And if you're going to eat it, then you should actually fry it or treat it in a way that will actually get rid of the microorganisms. And that includes both bacteria like Group B Strep or viruses like CMV.
All right. Well, on that note, let me go to the final question. And to close out the interview, Dr. McGregor, this is International Group B Strep Awareness Month. Can you tell me and my audience about the importance of this month?
Yes. I think Group B Strep was like the first instance of a congenital infection between the mother and the baby that we actually developed means to prevent. It's emblematic. It reminds us that there's many other kinds of infections, like over 30 or so, infections which can be transmitted from the mother to the baby using different strategies. And we're going to have to do better about recognizing these microorganisms, like the CMV I just told you about, by developing vaccines or other strategies. Because overall, I think actually we'll be more concerned about giving antibiotics like penicillin in terms of what's now called the microbiome between the mother and the baby into the future. And so this will become a bigger issue. So I think actually we're going to have to recognize that vaccines have been developed and may likely prove effective, like we have vaccines now for influenza in pregnant women, for pertussis, which actually are widely recommended by the CDC that you've been just mentioned, but still there's resistance, even though they prevent these terrible infections, which may cause the death of the baby. Mm-hmm. And so we'll be very interested to follow the progress in these areas.
All right. Well, thank you, Dr. James McGregor, for your time and expertise, sir. I appreciate it.
Thank you very much, Robert.